start with the take-home messages, in case you know. You can just take it and then you've got a dinner date or something on. In case you're in the wrong room. And I will also try and weave in some of my experience of how I got to where I am in terms of this topic area, because it wasn't the most obvious of journeys, and certainly not one I was planning in the traditional sense of that word. So just a little bit of a background. We didn't have a Students for Global Health type society when I was in med school, but I was the first year of the intercalated BSc in International Health at UCL. So we were the guinea pigs of that endeavor. And I think for me that was one of my first real exposures to public health in the sense of the scope and the scale of potential intervention for population health. Because who are the medics in the room? Are you still getting taught public health in medical school? Is it still really terrible? My experience actually was not particularly, it was kind of somewhat dry, and I didn't really see the relevance, and it was never something I thought I would do. I did the BSc because it appealed to me in terms of the scale of impact. I thought, wow, this is something interesting, something we're not taught, and let's see how it is. And one of the great things I got from that was a sense of community in terms of meeting like-minded medical students who really were driven by that desire to do something bigger. And so I wouldn't underestimate the value of this kind of association, just to pick you up when you're feeling like, when you're getting input like, but this is not what you're supposed to be doing. It's really important to get that. So I actually spent most of my research time. So I trained in internal medicine and then ended up in HIV because I did my BSc thesis on antiretroviral therapy because it was the years it was. I don't want to date myself in this room, but here there's some people. It was 2000, and it was when the Médecins Sans Frontières were piloting access to antiretroviral therapy in low and middle income areas. And fun fact, the title of my thesis was "But They Have No Watches," because it was a quote from the head of UNAIDS at the time who said, well, you can't provide antiretroviral therapy in poor places because they have no watches, they can't tell the time, how will they know when to take the ARVs? So my thesis was looking at, so this is not what you came for, is it? Was looking at the first data looking at adherence to ARVs in the first 6 to 12 months of those pilot projects around the world. One of them was in South Africa, so I got interested in that, and fast forward a few years, ended up going in, working clinically in HIV in London, and then going to do research in HIV in South Africa for 12 months, and stayed for 11 years. Okay, we'll pick up on that at some point. Remind me, if you're getting bored, just say, go back to the story. Okay, so take-home messages. 1, beware of the averages hiding the sins of inequities, right? Secondly, when I talk about NCD policy, I'm not just talking about, and we shouldn't just be talking about, health policy in the traditional sense. The third is really to achieve the NCD, the targets that we've set for ourselves globally, we're going to need to do much more than efforts within the healthcare sector alone, and will require collective multi-sectoral efforts. And lastly, because this is on NCD policy, you can't influence policy if you don't know policy. Right? And I think this is one of the biggest sources of hubris, particularly amongst medics, but general just health professionals. It's like, well, and researchers as well. You know, we have the answers, why is no one listening to us, but we don't actually take the time to get a sense of what we're trying to influence. So those are the 4 key things, and each of those I could do a separate lecture on each of those. So it was very difficult to decide whether to focus on one of those or to try and bring little bits, snippets of each of those, and so that's what I went for. What you won't learn is anything around the management of NCDs. That's just not what I'm going to talk about at all. Maybe we should leave the door open in case you want to sneak out or something. The other thing I'm not focusing on is any detailed epi in terms of numbers and anything you can find online, because you know what, you know, do your own literature review. I'm not doing your homework for you. So what instead I want to do is use some of these take-home points just to reflect on some of my experiences, and then we can hopefully not talk for very long, and then we can get into a little bit of a discussion. So in terms of the NCD trends, you think, well, how did I end up in NCD, given that I just stopped the story at HIV? Well, I did for a few years. In fact, my doctoral work was on the co-infection of HIV-TB, so the clinical epidemiology of HIV-TB, because no sooner had I arrived in South Africa did I realize you can't really look at HIV without looking at TB, because in that context, over 2/3 of TB patients are co-infected with HIV, and they're really one and the same epidemic. It's endemic in that way. So I did that for a while. And then I realized I was also doing some clinical work still at that point. So in the TB, largely in the TB clinic, but also a little bit in just the primary care clinic. And I started realizing that, yes, this is a really, really important syndemic of HIV-TB. The rollout of ARVs, so this was 2007 when I went to South Africa. The rollout of ARVs were in full swing, certainly in Cape Town. Really, control of HIV was, at the population level, fairly good and improving. But I also started noticing, anecdotally, at the clinic that, you know, you have people come in for the HIV treatment regularly, you know, religiously there, viral load, suppressed, excellent, everyone's high-fiving themselves, but we were still seeing premature mortality. Why? You'd have a 40-year-old come in with a stroke from undiagnosed hypertension who had excellently controlled HIV and was being seen every month. And I thought, well, are we trying to treat diseases, or are we trying to treat people? Because what good is it if we're saying, well, HIV is very well controlled, but we're leaving wide open the risk for other sources of morbidity and mortality. So I started wondering, well, how big a problem is this in this context? Because obviously, we know that South Africa was in the midst of some epidemiological transition, but you're kind of in the HIV-TB world, you think, well, that is somewhere else, because, you know, if you have HIV or TB, that's all you can get, apparently. So, so I started looking at that, and that's when I started realizing that beyond just the HIV-TB, we had this really iceberg of non-communicable disease epidemic that did not have the same profile or funding or advocacy even as HIV or TB. Okay, we'll come back to that. This is one of like 2 epi things. Having said that you wouldn't learn any epi, this is, honestly, I'm not really even going to talk through it. Suffice to say that when we talk about NCDs today, we're largely focusing on the 4 big NCDs, so that's cardiovascular disease, cancer, chronic respiratory, and diabetes. Most of my work is on the cardiometabolic, so the diabetes and cardiovascular spectrum, so the results of some of the work I'll share with you is focused on that. But, and the reason why is because really by vastly the majority of NCD deaths are due to these 4 conditions. And so at a global macro level, you can see huge variation, certainly at the country level, in the burden of the mortality from those NCDs. By the way, is everyone in the room familiar with the, should come into next, the global burden of disease studies? There's a lot of critique, and they're not perfect by any means, but it's a really great way of delving in to the subnational level on particular issues in a particular given setting. So let's start with England. What are your thoughts on this? So this is the years of life lost due to disability. Is that something that is that terminology familiar with everyone in the room? Is anyone not familiar with that? Okay. So when we talk about particularly around NCDs, because they're chronic, long time arcs, mortality, which is death rates, is one of the measures of disease burden we look at. But importantly, another is morbidity. So how much of, which is, so the most common, certainly in the GBD context, is used as a disability-adjusted life years, which is a combination of years of life, premature years of life lost, and years of life lived with disability. And that's important because that may not pick up in the mortality, but you're still not healthy, right? Because you have a deficit in terms of how far away you are from optimal health. So when I talk about years of life lost, years of life with disability, this is one of the terms related to morbidity. So any thoughts on this? What strikes? What jumps out at you?
Well, low back and neck pain is really high.
Isn't it just? Any other thoughts?
The increase in diabetes.
Increase in diabetes, yeah?
And that fall, they're actually above diabetes.
How do you think that is?
Why that is?
Sorry?
Why that is?
Yeah, yeah. What would you think?
I'm not quite sure.
What's the demography of the country? Apart from diabetes, not a huge change across that time arc.
Medication habit?
Sorry?
Medication habit.
Yeah, what is that about?
GTN spray for angina that could cause headache, and so if heart problem increase, then this might increase.
It could do. What's another reason that you always have to consider when you see things that you're not sure about, you're not expecting?
Changes in the way it's measured.
Yeah. Over between 1990 and 2013, you've just got to go back and see, well, have they started measuring it a bit better? Have they characterized it a bit differently? I don't know the answer, but just something to always consider, especially when comparing data over long periods of time. But by and large, NCD, right? So it's just a sea of blue. When we come to the risk factors, common risk factors for the NCDs, this is again England. This is comparing 1990 again to 2013. What are your thoughts here?
I kind of thought smoking might be number one, but it's further down than I thought.
Not only is it further down, but it's gone down.
Body mass index and possibly the quite a bit, yeah.
Right? It's pretty striking. Is that surprising? Why, you pessimists?
it's an issue of recording. Between sorry, I'm an old man, so I know this. Between 1990 and 2013, every general practitioner had to record and submit these parameters on all their patients they saw, and they got paid for doing it.
Right.
And therefore there was more data in the system, especially around body mass index, glucose. I don't know whether that's the iron deficiency, I'm not sure. High blood pressure, smoking, they all had to be recorded in alcohol.
So it's interesting where when you see results that you're surprised by, you question them, but when you see results that you're not surprised by, you're like, oh yeah, that just validates what it is. Don't forget to be critical, even of what you expect, something that affirms your belief. Right? Okay. So just we'll pick up on the BMI and glucose again, you know, in this one. This is the last UK, England rather. So this is a heat map essentially. You don't need to be able to read it, right? Before we even talk about the axes, if you just look over here, what can you deduce? What patterns can you see? Just very literally. Cross your eyes even if you need to. Sorry?
A lot of variation between different areas.
There's a lot of variation. Can you see any pattern? Or is it all scattered?
It's related to the deprivation.
No, but let's just talk about this first. So there's lots of variation. But if you cross your eyes, do you see any pattern in the variation?
It goes from green to red.
It kind of moves from a lot of green to a lot of red. Okay? So that's the first thing that should jump out at you before you go in. Just don't dismiss that knee-jerk. You saw it, but you didn't necessarily register it. So along the lines here with some of the different morbidities, so diseases and conditions. So from ischemic heart disease, again from left to right, lung cancer, COPD, etc. From top down is from deprivation level 5, which is good. Deprivation level 1, which is bad. So now what is the pattern, obvious pattern that you see? Right. But it's the same country, same people. Why is it? And if you look at the middle, obviously it's pegged to the middle, so that's why it's all yellow in the middle. Right? So this is above, lower than the mean, so less burden than the mean, and higher burden than the mean. So obviously the mean is all yellow. So the point I want you to take home from this is that if we just looked at England, like we talk about South Africa, or we talk about Canada, or we talk about Australia or New Zealand, and this is the line we're talking about. What it doesn't tell us is what is inside. And so when you start thinking about NCD approaches to NCD prevention and approaches to NCD management, it's important that we're cognizant that we're not saying, okay, this is the policy for England, let's do it this way. Because in the context of limited resources and competing priorities, do we just say we need to roll out this intervention across the country? This is South Africa, so there's the country, and these are the different provinces of the country, so there are nine provinces. What do you see?
Quite similar. Quite similar among the provinces.
Right. So by and large, there is certainly the bits down there, the blue bits of blue, but across the board, some splatterings, but more similar than the previous. Yeah? Somebody said something?
What do the colours mean?
So, yeah, so these are the rankings of the risk of the contributions of these risk factors to overall morbidity. So childhood undernutrition is hot across the board because it is the top in 1990 risk factor contributing to disability adjusted life years.
It's more blue and less.
Yes. So, yeah.
The top 5 are completely different from England
Mm.
in 1990.
Mm-hmm. Yeah. Okay.
A lot to do with nutrition, hygiene, and sanitation.
Mm. Okay. Let's fast forward to 2015. What do we see now?
Same.
Or chronic profile,
Yeah.
chronic
Yeah.
disease profile.
Looks more like England.
Right?
Yeah. High body mass index, blood pressure, upper glucose.
Although I do have a separate lecture on epidemiological transition and the fallacy of it, but I'll spare you about that now. Obviously unsafe sex is top because, because it spanned the hump of because 1990 was pre the peak of the epidemic in South Africa. But huge increase in high body mass index, glucose, blood pressure. It wouldn't look exactly this way, by the way, if we remember this is morbidity. Mortality hides a lot of that to some extent because mortality favors more acute and more infectious conditions. So you often don't see, it doesn't feature here, but mental ill health, huge contributor to morbidity. Violence, injuries and violence. But interesting that when you break it down into the different provinces, it doesn't appear to have as much variation as in the UK. What I won't show you is that Western Cape is where Cape Town is, the province of Cape Town. I didn't put it on. I knew I should have put it on that map to show within Cape Town the variation in this. So even though this is disaggregated to the level of the province, it hides a lot of inequity within each of these provinces. If we look again, looking a different way, and this is more now focused on the conditions themselves. The text is hard to read, so a shortcut. Blue is NCDs, red is infectious, green is injury and violence. Anything above the 0 line has gone up between 1990 and 2010. Anything below the 0 line has gone down. So again, without reading, what can you see?
A lot of NCD has gone up.
And
Violence.
And
elephant in the room. So when I started worrying about the way that the kind of narrow focus of my research on HIV/TB, I suppose it's not narrow because it's quite a huge epidemic, I started wondering about, so we see a huge amount of HIV here, but still coexisting with a lot of NCD. I started wondering, well, yes, this is occurring within the same country. And traditionally we think about NCDs as, as you develop, you increase, the Omran's theory of epidemiological transition, you kind of develop and then you get kind of slower and fatter and then you develop NCDs, right? So surely it's different people because we know HIV/TB. So I started wondering amongst the people that I was seeing, what the patterns of comorbidity was. So the first thing I did was look just within, so recognizing that we know there's a lot of undiagnosed disease, particularly NCDs, because it can not show for a long time. Okay? I thought, well, let's just look amongst people who are attending the primary care clinic, so who are already receiving treatment. Because, so I worked in Kailicha in Site B. So Kailicha is the largest informal mixed formality neighborhood in Cape Town, and maybe the second largest in South Africa. And within that, there's this big primary care clinic, and you drive in. There's a gate, and on the right, there's a big car park in the middle. And on the right is the HIV/TB clinic, which basically MSF squatted because, and then became a government facility afterwards. But I mean, I think you know the history that MSF would start providing antiretroviral therapy whilst the government was still in denial about causes of HIV. But on the other side of the car park is the primary care, so the general outpatients and the A&E. So you have diabetes, and you've had it for a long time. You come into the compound, you go left, you go to the reception there, you pick up your folder with your particular unique folder number, and you go in and you get seen that way. And then one day you start coughing and you wonder whether there's something there, and you worry about TB. So you come in and you go right, and you have a totally different folder that's not connected to that one. The person that's seeing you there is not asking you about your diabetes because they don't know, because you're here for TB, and it's a TB place. So what we ended up with, to a large extent is still the case, although it's changing, it's this very siloed health system that was really very vertical and very disease-oriented, and split into this chronic infectious, which is kind of HIV, TB, and chronic non-communicable and everything else in there. So sitting in the HIV, TB clinic was very difficult for me to figure out. I couldn't just look at our patient folders to say, well, how many people have diabetes, who's been treated for, because they were in a different folder, in the same, across the way, right? Different pharmacies, different, etc. So we did a study to look at, essentially, over a 9-month period, all the patients that were being seen for one of 4 conditions, for HIV, for TB, for diabetes, and for hypertension. This wasn't in Site B, this was in another clinic in Kailicha. We did that just using the electronic prescription records, because we had that, but they were separate. The folders were separate, even though each patient has a unique patient identifier, right? You follow me? So we're able to link records of patients that were not linked on the ground. So if I say that we found that of the 4, so this is just, remembering this is just the tip of the iceberg, this is amongst people who are already being treated for one of those 4 conditions. If I say that that almost a quarter of people had a second comorbidity, and if I said, so that was amongst HIV patients, what would be the comorbidity that you'd guess? Based on what I've just said about the syndemic and with HIV, TB, right? Because your risk of TB is just exponentially increased with HIV. It was hypertension. Hypertension was by and large the most common comorbidity. Why was it the most common comorbidity in HIV? Because it was just the most common comorbidity, period. And HIV infected patients were not exempt. Surprise, right? So I started thinking, well, okay, so because I promised not to show any graphs, I didn't put this into slides, so you have to listen to my story. Yeah. So I started thinking, well, okay, so we're treating people separately and picking and missing these comorbidities that are actually more the rule than the exception, if you like, so not rare enough to not routinely screen for them. But beyond that, I started wondering, okay, so we have this huge hypertension and diabetes prevalence burden. Firstly, I started wondering two things. Firstly, why are we not thinking about that in the context of people with a pre-existing chronic condition, be that infectious, because HIV really is a chronic infectious disease, and TB somewhat because of the period of time you have to be treated for. And secondly, why are we not as a health system thinking more holistically about those pre-existing conditions? But this is not, we're still talking disease here, we're not talking health. Okay. So, fast forward a little bit of time. At this point, I was infiltrating an immunology group as the only public health epidemiology person in an immunology group. You can imagine how happy everyone was when it was my turn for journal club. It's like, where are the cytokines? So I moved at this point to this School of Public Health because I started thinking, well, I think I want to go back upstream and get a sense of what is this burden and these patterns, are they inevitable? What can we do? What is driving this transition that we see? How can I think beyond just, okay, one aspect is how can we treat them better and treat them more holistically, but also these are preventable conditions. So what are we doing within the health care sector to prevent them? And I realized best case scenario, what we were doing is at a hypertension club, which is where people who have, fairly stable hypertension, very loosely defined because of the burden, you would have 10 minutes before each club where the health promoter will come in and like, everyone stand up, touch your toes, do a bit of this, here's a pyramid, etc., etc. And then we were happy that we've done our bit of health promotion to improve their treatment. And there was something very weirdly complicit about, okay, I'm the doctor, I'm going to tell you a bunch of things to do that I know you can't do, but you're just going to listen and say yes. Mm-hmm. And as the patient's like, I'm going to listen to a bunch of things that I know I can't access, but I'm just going to pretend like I'm going to do them. Are we good? Okay, let's go. So there was something really weird about that dance. So I know you need to eat better, you need to walk, and they go, yes, doctor. I know it's not possible, because the second you walk out of the clinic, you look at the food system around you, the food environment around you, and there's nothing about it that was making a healthy choice any way easy. So anyway, so I moved into public health at that point. Maybe a couple of years before, actually, I did the public health registrar training in South Africa. I didn't mention that, because I wanted to get a better sense of the health system and what was behind, because I was doing some service provision, I didn't quite understand the health policy and what drove that. So when I moved to the School of Public Health, I set up this research group called REACH, called the Research Initiative for Cities, Health and Equity, because obviously the context I was working in is the city. And I started thinking, well, how can we look beyond just management and secondary prevention into addressing this epidemiological transition? So one part of the group was looking at this multimorbidity and trying to better understand and characterize this multimorbidity. and in order to inform and evaluate models for integrated care at the primary care level. The other aspect was looking at, and these, one is completed, there's some papers out on that, and the other is ongoing, looking at HIV NCD prevention in the context of adolescence. So in adolescents with HIV, so chronic disease, what can be done, what research can, what information can inform strategies for NCD prevention. And one of the things I found is, you know, we're all very obsessed about teenagers having sex, for obvious reasons, but that is kind of the focus of our adolescents' health. So it's sexual reproductive. But we had adolescents who are often invincible, as you might all remember from your adolescent days. And so nowhere, generally not normally anywhere to be found near healthcare facilities. So you had adolescents with a chronic condition, HIV, so we had access to them, and yet the system was set up such that we would just continue seeing them for the HIV until we start seeing them for their hypertension as well. Does that not strike you as completely, why are we not talking to them, why are we not better understanding the ways in which we can address NCD prevention in this group of adolescents who we are a captive audience because they are coming in regularly? So that's another project that's ongoing. Don't have any results yet other than the first bit. I can tell you the spoiler, looking through the folder reviews to get a sense of, before we actually started interviewing adolescents, to get a sense of how much NCD-related information is captured in their adolescents' HIV folders. So related to BMI, blood pressure, eating, physical activity, smoking, alcohol. What do you reckon? Very little. Yeah. Incidentally, I should mention that the multimorbidity study I did, when we looked at the 9-month period, the 14,000 people in Kailicha with one of those 4 conditions, one of the things that we found was that those, when you compare those on antiretroviral therapy, and I say that not HIV positive because obviously we were categorizing them based on their prescriptions and not on the diagnoses. But when you compare those with on antiretroviral therapy to those not, the rate of multimorbidity was significantly higher in the 18 to 25 age group in those on antiretroviral therapy. And this kind of supports some of the work that we know has been proposed around the early aging effects of HIV. Right. So it does seem like the risk of some of those NCDs are higher or occur at an earlier age, HIV, and yet with the huge population of adolescents with HIV, we were not really bringing in NCD into their care. Okay. Oh, I'm going a lot slower than I intended. Speed through. Any questions on that? That was the first take-home message. The second was that NCD policy is more than NCD health policy. And I say moving from NCDs to NCDDs, so moving from just thinking about NCDs, moving to NCD determinants. So I'd really like to incorporate a stutter into your NCD lingo. I will use the concept of the urban to speak to this. Okay, so this is something that this room is likely very familiar with. The notion of the iceberg, that what we see in the healthcare sector is just the tip of the iceberg in terms of the health profile. Below that lies a lot of the drivers of ill health, from education, housing, work, your food environment, etc. Of note, pretty much all of those fall outside our remit, right? So we know that a vast, overwhelming majority of factors that influence health, that contribute to health, actually lies out of the health sector. And so when we start thinking about primary prevention, we start to understand actually why this is not a popular area of research, because it's kind of complex in terms of, not complex actually, just messy, because everyone's involved, right? This is actually where you need to be if you're thinking about primary prevention by and large, or certainly be active in. And then you kind of longingly look back up to the iceberg and think maybe reminisce about the simpler days. This is my attempt. My PhD student loves the S's, so I just keep bringing it up. I started thinking about, well, how can we, so if you look in the background, this is when we think of a city, right? We often think about buildings or whatever. So how can we, as health professionals, move from seeing the built to actually seeing the determinants of health? So I started thinking about, well, how would you break up the urban into exposures? What would that look like? And I started with sugar and salt, and it kind of sounded good, so I just decided I was going to stick to S's. So some of them are a little bit contrived because I couldn't change after about 4 S's in. So on the right, you have some of the most common non-communicable diseases, and on the left, we have some of the common urban exposures that we know. Certainly, recognizing that rural-urban is a continuum, and I don't want it to come across like as a dichotomy, whereas in reality we have this form of continuum. But characteristics of the urban that drive that are driving some of these NCDs. So really moving from thinking about those NCDs to thinking about these NCDs. And I realized that essentially in the work that I was moving into, I wanted to focus more on the NCDs. So when you look at that, you start to wonder why. Because none of my training really, then we need to start preaching the need to internalize that, not just within the NHS, not just within the healthcare sector. So I kind of, I see myself as a healthcare professional because that was my training, and a health professional because I don't have a disease that I stand by, because most healthcare professions do have that disease, right? One of my best successes of the sermons, by the way, I gave a talk at the Royal Institute of British Architects, to a room of architects and planners. And I totally, oh no, you're recording. But I totally ambushed them, because at the beginning I was like, oh, who are the health professionals in the room? And by the time I was done, I'm like, who are the health professionals in the room? Like, we're all health professionals! Because one of the challenges that I've come across in my efforts, and I'll talk a little bit about when I talk about it. One of the studies I looked at, I'm just going to say it now. We looked at, so we did a study looking at health and housing policy, right? Because it's one of the S's. And one of the key barriers that we found to, because one of the great things about public health is it's not rocket science, right? It's the most logical thing. It's like, we know what we need to do, you know. So no one's going to say, well, I don't agree health is that important. You know, everyone's going to agree with you. Everyone's going to varying degrees, see the relevance, potentially, of what they do. But the governance of the NCDD world is not aligned and focused on health creation as an outcome. So without the internalizing of the, I'm an urban planner and I'm a health professional, in what ways is what I'm doing impacting on health, and what can I do about it? Where we end up living in is this fallacy of trickle-down health. that we will just all do a good job at what we do and health will magically follow. We know that's not true. Actually, it is true for places that are, for groups of people and communities that are already healthier. The Greens, right? In terms of access to those health promoting environments. But we know that without concerted effort and looking at, well, what is the health, what is the disease burden, what are the health needs of this population, what are the ways in which this particular urban exposure impact on that burden, and what are the ways in which what we do, what are the health impacts of what we do, and do they reach the people where the burden of disease lies? Without that follow through, what you end up with is, I don't know Cambridge that well, but what you end up with is bicycle lanes in the middle of the city where everyone's already cycling anyway, and really it's not where the obesity or the diabetes is. But they've done some really good work. Bicycles are good, right? But without thinking consciously about the first take home around inequity, without thinking consciously about, what's the second take home? NCDD? Yeah. Without thinking about NCDDs, without thinking about yourself as a health professional, irrespective of, because you are in the NCDD world, what you end up with is missed opportunities to harness the environment for health creation. Why did I put this here? Oh, maybe it was just to give you a list of things because I said I wouldn't. But just to check in, so in thinking about the global, some of the global targets for NCDs, who knows anything about this policy document? Do you want to talk to it a little bit?
A lot of language, like the relative reduction in prevalence of insufficient.
You got it right. Everyone's got what they need to do. Okay, so these are the 9 major global targets that the WHO has set based on the action plan for NCDs by 2025. I have somewhere I've got a slide that gives you some of that breakdown of policy. I'll come back to that. But I started thinking, and this is just to demonstrate some of the work that I do and just to give you a glimmer into my headspace. If this is where ultimately we want to impact, so the health outcomes, this is what we're about, right? Equitable improvement of health outcomes, be that in the long term or the intermediate. We know that certain exposures influence those health outcomes, and largely because we're talking about health, we think about health services. So I started thinking, well, if we think more around NCDs and we think more around who a health professional is, then can we think differently about what a health service is? Okay? So we start with what we know, the healthcare service, right? Which is largely related to disease management, right? Secondary prevention, some exceptions obviously around the first 1,000 days, around prophylaxis, palliation, etc. But by and large, the exposure to the healthcare services are determined by the dimensions of access. So these are the 5 A's in dimensions of access. I like my number and letters, so it's 5 A's. It's not mine, by the way, but I wish it was. Availability, accommodation, affordability, access, accessibility. So there's some of the exposures. The intermediate outcomes are things that we can easily measure in terms of, the healthcare episodes, how often you're accessing healthcare, your admissions and the usual markers of disease control, and ultimately trying to reduce morbidity and mortality from those conditions. That's where we largely, as healthcare professionals, tend to stop. But if we think differently, can we think about habitation and planning as a health service that informs those kinds of exposures that relate to those intermediate outcomes and that significantly contribute to those long-term outcomes? Can we think about transport as a health service and think about some of the exposures that our thinking and transport policies relate, what kinds of exposures they result in, what kind of intermediate outcomes they influence, and what kind of long-term outcomes they contribute to. When we think about waste, water, sanitation in a similar way, when we think about food in a similar way. So then you start thinking, well, why do we only just talk about the bit at the end, where largely we're talking about disease? So start asking, in this context, can urban services and exposures be harnessed positively to influence health? So beyond understanding and better characterizing the ways in which they contribute to exposure and intermediate outcomes, a lot of which we somewhat know, either with evidence or anecdotally, but can they be harnessed? And if yes, how? And by whom? So in addition to the health system side of the research group, has set up this systems for health. Right? So how can we harness those health services and start thinking in that way? I talked a little bit already about the health and housing project, and the food systems is another one. I'm going to rush through this because I talked a little bit about it, other than to say that, and I'll say it again at the end, something like the WHO that you don't normally think about in the context of outside of the healthcare, they've characterized dimensions of housing that don't relate just to the built structure, but also the psychosocial home environments, the physical characteristics of neighborhood, and the social environment. So that was just to mention that. I talked a bit about that. Let me talk about the second system for health. So this is, I came back July last year. Right, so I've been in Cambridge since then. And I'm within the Global Diet and Activity Research Group at the MRCFE unit. We have some NIHR funding to look in those different countries, working with those different partners at essentially meso and macro level approaches to NCD prevention through addressing diet and activity. So one of the studies that we've got gearing up to start is looking at, in the context of adolescence, and I've got a bee in my bonnet about adolescence and what we can do. We're looking at trying to better understand their lived experience in the context of their built and food environments, matching that with their individual level knowledge, attitudes, and practices. We're looking at, because one of the interesting things about adolescence is that whatever you think they're doing, it's not that. And so looking at the way they navigate the urban environment through their eyes to better understand potential urban acupuncture points that would actually speak to that population group. So one of the cool things that we're planning, I don't know if I should say this on camera, but we're going to be looking at the journey to school. So having them on as citizen scientists, so they participate with the data collection, to say, what is your exposure? What are your S's on the way to school? What do you interact with and why? And what do you miss and why? And that might relate to retail in terms of what you can buy. It might relate to advertising, what you see, what you hear, etc. and then use a kind of qualitative, so geocode where that is to get a sense of what they, because this is where they spend most of their life really, you know, going to from school in terms of time frame. Looking a little bit at the school environment, so within and around the school, around the opportunities for the food environment and the built physical activity environment. And then really using qualitative methodology to look at working with the adolescents to better understand how they process that the data they collect, which is a combination of text and photo and GPS. So what we hope to do is to also better understand the ways that the environment that they're exposed to, so within their neighborhood and then on their journey to school, impacts on the choices they make and their understanding, the ways that their peers and that interaction influence what they end up doing. And the idea and the hope is that we would use those results to co-design with the adolescents potential interventions aimed at, not at the individual, but aimed at the environment, so at that meso level, be that in the neighborhood or school or somewhere on the journey. And one of the exciting things about this, I think this might be one of the first times where I genuinely don't know what we'll find. I really don't know. Last point. Who knows why I am suggesting evidence-based policy is a myth? Or who can suggest why? You couldn't really know. Agree, disagree? Scandalized?
Yeah.
Scandalized?
Yeah.
Okay, cool. Yes, I can get that. Okay, let's take a step back into policy. Has anyone seen that before? So this is policy triangle that was developed by Lucy Gilson. I know her first name because I worked with her, and somebody, Walt, because I don't know her, who were public health health systems researchers, to think about when you, so it was largely developed in the context of health policy, think about what are they, if you want to understand the health policy environment, what are the key components of what you look at. So they have characterized this into the context, the content of the policy, the process through which the policy was developed, because that tells you a lot about what will work and what won't work. And right in the middle of that triangle are the actors. And what I like about this and you realize how easy it is to not do one of those when you're thinking about trying to understand the policy. Because we normally just go to content. But who was involved in the setup of the policy? What was the pivotal moment? Who said something and everyone said, yeah, we should do that, that sounds good. What was the context at the time? What made it come up and make it adopted? And what was that process? So that's something that I thought it would be useful for you to know. This is something that's been around for a long time in health policy research. I want to talk about more broadly around advice and evidence advice. So this diagram, when it's done, was adapted from a guy called Professor Peter Gluckman, who was the chief scientific advisor to the Prime Minister of New Zealand and established the International Network of Government Science Advice, recognizing that there was a need to pull together some of the expertise, whether it's from chief advisors to right through to the researcher, to better understand the different mechanisms through which evidence is fed into policy. And one of the key things I learned from going on the training workshop a few years ago was how much I just assumed that, you know, I can't understand why you wouldn't do what we've just found, because we've just done some really awesome research that is really relevant. I'm showing you the results. I mean, what more can I do? And I'm starting to understand the limitations of that approach, which, as I say out loud, perhaps might be obvious. But we still all do this. So we think science feeds into policy. But in reality, the best you can hope for is evidence-informed policy. I can almost confidently say no policy is based on evidence. Right? Hopefully, you have some evidence going in and informing the policy, and the job of the policymaker is to consider that alongside the context, the culture, the history, other policies in the city, other policies in the region, other policies in the country, and to make those decisions around trade-offs. That is the job of the policymaker. But we think, no, but the science has told you exactly what to do. Why don't you just do that? We also forget the role of society, except for around elections and referenda. And we wish we could forget. It took an hour before that came up. But given that policymakers are largely elected, the society actually plays a huge role. So one of the great stories that he tells, which I'm just going to plagiarize, is he talks about one of the first tests that he came across was there was discussions around whether folic acid, whether all food should be enriched with folic acid. And there was huge outcry, you know, Frankenstein foods, and all of that. And the usual intellectual kind of response to that is to go, oh, come on, it's so obvious. Why would you not just, you know, think about spina bifida, think about the risks, the benefits? It's just a no-brainer. And at the time, I don't know what, it was a few years ago, I don't know where it ended up, because New Zealand's kind of rocks right now. Okay, but anyway, let's not get into politics. At the time, the policymaker decided not to go with it. And so the media was like, well, how do you feel about being ignored as your first thing, as your first task? And he says, well, the policymaker made the right decision for the policymaker, because there was a lot of input from society into the policy. But the people rolling their eyes and going, we're doing very little to feed into that. And so that was the right decision for the policymaker in the context of their job description. We have a responsibility to understand the policy landscape, to understand the ways in which what we know, whether it's from our practice or from our research, can feed into policy, and to advocate where it matters. Because without that, they make the calculated decision that might seem obvious to us. We also forget the science and society link, right? We forget that in addition to, it's not just Gwyneth Paltrow that can tell the society the latest health advice. Right? What are we doing to indirectly influence policy about that? So that was the myth of evidence-based policy. So very lastly, the last bit I'll touch on is around that global, thinking about the global context. So these are, of course, the SDGs. familiar to everyone. Yes, obviously. I like this adaptation, firstly because it puts health in the middle and what's not to love. But secondly because it essentially goes through the different targets. Oh my goodness, I didn't credit that. I think I've got it in the last slide. It goes through all the different SDGs and the targets, identifies ways in which those NCDs speak to the health target. I.e., when we talk about SDG 3 as the health target, what else is the health target in SDGs? Again, it's just changing the way we think about health and about our remit if we really are to improve health. This is the slide that I spoke about earlier. This gives you a sense of not really speaking to it other than just to let you know it's there, that there is a wealth of global level NCD policies. So this is just between 2013 and to last year. Some of the data that I showed initially around the targets come from the Global Action Plan for Prevention and Control of NCD. This gives you a sense of some of the policy landscape. What I haven't juxtaposed on this is some of the policy processes that are in place, or a little bit, around the UN High-Level Political Declaration, the UN Task Force for NCDs, and actually last year was the second time that the UN General Assembly, not the WHO, the UN General Assembly, had a health issue on the agenda, and it was NCDs. So the only other time that's happened was for HIV. So that gives you a sense of how high up on the general agenda, so this is not a health meeting, NCDs are, including mental health, which is quite awesome, because that's often neglected. So I'd really encourage you to appraise yourself with some of these processes, but also ask yourself, how are these being translated into your national landscape? Do you know what the East of England policy is on any of this, how they've translated some of this? So there are some best buys around the Global Action Plan. Do you know if the city of Cambridge has anything on this? That's where you need to start, right? So a lot of these global things are set the agenda, but they have to be implemented nationally and subnationally. So if you don't know how, we all operate on a deficit mentality, right? Because we see the burden of disease and like, no one's doing anything up. Really, are you sure? Are you sure before you say that? Because you just ask your mate and they also didn't know, right? And sometimes you'd be surprised at when we were looking at the health and housing policy research, and we were looking at essentially opportunities for intersectoral collaboration. So are there any policies that exist already that we can already, outside of the health sector, that are already kind of dancing around health that could be the way to go? Because there's no need to start from the beginning and invent something from scratch when there is a low-hanging fruit. And one of the things I was really surprised by, because obviously I expected it to be nothing, because it's all siloed and it's all vertical, and thank God I'm here. Actually, what I found was that there was quite a lot of policy documents and strategic plans around wanting to integrate the different sectors. We can talk about implementation and the deficits of that, and I think that was definitely an issue. But if I didn't actually have it as one of the objectives, I think I would have just assumed that there was none and started from there. But what about the NCDD policies? This is where it starts getting, oh my goodness, that's just where do you stop? Because there is a wealth of global level policies that relate to NCDs but exist outside of the health sector that you will not find on the WHO website. Right. Does anyone know about the New Urban Agenda? Right. So this is a Habitat 3. There's been a meeting every decades or so. And there was most recently in 2016 in Quito. And so WHO did some work around looking at how do we put health into that New Urban Agenda. Because we're talking about the exposures that drive the burden of disease we see. Does anyone know that, oh yes, that's it. This, that circular document around the SDGs and the way interaction came from this. This is a really great publication I'd recommend to look at different, the ways that different SDGs interact and some of the gaps in terms of the knowledge that it was not just health but there's some health things there. UN Habitat is getting into health, right? Obviously, because it's on habitation. So this was just published last year. So it gets case studies around incorporating health into urban and territorial planning. And later this year, there will be a look out for it, a UN Habitat Health and Urban Planning Guide. So this looks at different ways, and this is very relevant to NCD. So would you think to look for NCD policies on the UN Habitat website? The WHO just released, this has been almost a decade in the making, housing and health guidelines in November last year to summarize some of the evidence on the different ways in which housing, using all those different dimensions of housing I mentioned earlier, different ways that they impact on health, both infectious and non-communicable. And actually I didn't put that there, but you absolutely have to look at, okay, very excited about this, awesome reading. You also have to look at the the Global Urban Health Report. So that was a joint report between WHO and UN Habitat. There's two, Hidden Cities and a Global Urban Health Report. So if you're thinking about NCDs in this way and you're trying to think about, well, this NCDD world, because we are so focused suddenly as health professionals, care professionals, correction, in our sector and the kinds of data that we access and the kind of literature that we access. This is a good place to start. Yeah, because this looks at, get a sense of the opportunities to contribute, to address that valley of death. Because if you don't know what's going on, you don't know what your place and what your role is and what you could do. So those are the take-home messages, just to recap. Only one person left. Averages, beware, inequity, huge. Think about NCDs beyond health policy. Think about health professionals beyond healthcare. And lastly, know your policy landscape and think very broadly when you do that. Because really, if we're going to address the NCD burden in many, at the population level primary preventions are going to be our best bet in the long term because we're unlikely to be able to treat ourselves out of this epidemic. So I'll end there by thanking this, by the way. I know this looks like something a professional drew, but would you believe I did it? Oh, I know. This is my way of thinking about NCDs, like in the city, pushing you off the cliff, and we're just healthcare waiting to save you from drowning in the ambulance. But how can we reverse that and think about the ways that the city and the environment can not just push us off, but actually help promote health? And that is definitely not EU level emissions of the ambulance driving off, because we're reducing the need and the demand for healthcare. So I'll stop there.